Mujugira from the Infectious Diseases Institute. He's a clinical epidemiologist and senior research scientist and a mentor to so many people at the IDI. He's got 14 years of experience in HIV PrEP studies, efficacy trials, and several implementation science trials. He's got several funded projects from the NIH, and his research niche is building self-efficacy, empowerment, increasing adherence to ART, and reducing sexual risk behaviors among key populations. So at IDI, we like to think of Dr. Andrew as a man leading a solo mission, sometimes against a very pertinent population, which is a key driver to infection. And that is the key population, which has a high contribution to HIV spread. So you're welcome, Dr. Andrew. Thank you.
Thank you, Dr. Dungu. COVID sometimes makes us forget that there's a lot going on the African continent. As you can see, the WHO is monitoring about 154 ongoing events. We have Ebola virus disease outbreak just next door in the DRC. We have a Lassa fever outbreak in Guinea. And COVID-19 is surging again as Southern Africa goes into winter. And the epidemic curve in Southern Africa, the fifth wave in South Africa, is underway. It's also important to remember that many of our fellow healthcare workers have been affected or infected by COVID, and sadly, some of them are no longer with us. They would have been here with us, but we remember them. This is really a story of two pandemics. We remember that we have HIV, as my colleague has just been telling us. A study presented at CROI looked at HIV incidence estimates for 12 African countries, a total of 316,000 new infections. And the take-home message is HIV incidence is twice as high in women as it is in men. And as you can see, women account for more than half of all new HIV infections in sub-Saharan Africa. You can see right there that incidence peaks between the ages of 25 and 34 for women, and a decade later for men. So as Nyarazo was saying, we really need to scale up HIV prevention options and give women choice so that they can choose options that work for them. The other pandemic, as we all know, is COVID, and the WHO recently released a review of 151 seroprevalence studies showing how prevalence on the continent rose from 3% in June of 2020 to 65% in 2021. So at least 2/3 of Africans have been infected with COVID. And the interesting factor here is that only 1 of 100 COVID cases on the continent has been reported. There's a lot of COVID that is unreported. And probably one of the protective factors we've had is that we are predominantly a young population. The WHO estimates that up to 67% of infections are asymptomatic. So coming to Uganda, we had a COVID lockdown between March and October, where we shut down the airport and borders, and there was a lot of restrictions. And that really hit our HIV service delivery. There was a reduction in testing by about 1/3, a reduction in ART initiation, and a decrease in viral load coverage. So a hit to the HIV care cascade across the cascade. And worryingly, there was a decrease also in PrEP use for sexual assault, data presented at IAS last year. We did some qualitative research to try and better understand the impact of the COVID pandemic. The lockdown was unexpected. We had a fantastic discussion at lunch. Where were you when the COVID lockdown happened? Some of us were attending weddings in other countries. Others were in transit going to Boston for CROI. And many of our clients were caught unprepared with few resources to navigate their changing circumstances. The lockdown made access, as we know, to HIV care quite difficult. And so because public transport was shut down or restricted, people could not afford transport because fares went up. We had to physically distance within the vehicles. So clients used to walk, often very long distances. And then because there was food shortages, it was hard to walk when you're hungry and you have fatigue. And yet, despite all these challenges, our clients found resilience or ways to cope with getting their care. We found from our qualitative work that the lockdown reduced the ability to generate income needed for food. And so the economic instability as people lost jobs or went to reduced pay resulted in food insecurity, making it more difficult to take PrEP or ART. Quote, "Our living situation is not good because it is now hard to get what to eat and drink because of the current situation of COVID-19, since we are unable to work like before. It is really very hard to find something to eat and drink. When we are lucky, we can get a 1/4 kilogram of posho, which my sister Nyaradzo calls sadza, and eat that. I have friends whom I can go to and ask to give me some posho at a loan, and when I start working again, I can repay. What makes it worse is the strong medication that we are both taking, which really affects us so much since we have little to eat. This makes me feel so weak." Participant on ART. So now I'm going to focus on 6 populations at high risk of HIV with whom I'm privileged to work and do prevention research. Adolescent girls are hard hit by the COVID-19 pandemic and experienced what has been called a shadow pandemic of sexual and gender-based violence. It is estimated that school closures increase the risk of child marriage by about 25% per year. And in this country, we saw that happen to our young people, culminating in press reports of girls getting pregnant and getting married. The picture shows a 14-year-old girl carrying her baby, and she was impregnated by a 28-year-old man. Disruption to the social and protective networks, that is schooling, resulted in nearly a 400% increase in pregnancies of young girls between 10 and 14. And this sexual and gender-based violence was experienced across the country, and more than half of the districts in this country registered increases in teenage pregnancies. Moving on to serodifferent couples, we analyzed the impact of COVID lockdowns on ART use among nearly 1,400 serodifferent couples enrolled in a step-to-age cluster randomized trial, which we conducted at 12 HIV clinics here in Kampala. We analyzed 3 time periods, each of 6 months. Period 1 was the time before COVID lockdowns. Period 2 straddled the time between COVID, before the COVID and during the COVID lockdown. And period 3, the 6-month period during the COVID lockdown, at which viral load was assessed. As you can see, baseline characteristics were evenly distributed among the periods, but you can see that the time to viral load testing was about a month longer during period 2 because of the restrictions on transportation. And viral load suppression was also mildly lower in period 2. However, pairwise comparisons of all 3 periods were not statistically significant. We also saw a mild increase in HIV, WHIV disease severity in period 2, but that also was not statistically significant. These data are going to be presented by my colleague, Dr. Mwonge, who will be presenting poster 33. Most couples enrolled in this cluster RCT reported changes in service delivery. Because the clinics were decongested and had fewer staff, and there were fewer services available, it also meant that there was less time you spent in the queues for medication, a sort of blessing in disguise. Quote, "The difference is picking drugs during Corona, meaning COVID-19, was so much easier because they didn't spend a lot of time while there, unlike before. Whoever came would be worked on immediately, since the health workers were avoiding big crowds. Yet before, you would wait for a long time to be worked on. In my mind, I started thinking that Corona was a blessing in disguise for us to spend just a few minutes when you go for drug refills. which was unheard of. And this was a female client taking ART. Switching to pregnant women, a large study, observational study, was done at one of our hospitals here in Kampala, comprising about 14,000 antenatal visits and 33,000 deliveries before and during the lockdown. The analysis found that HIV testing declined by 4%, so it was a little dip, but reverted to baseline thereafter. And the number of women attending PMTCT services dropped, but also rebounded back to pre-COVID levels. For pregnant women living with HIV who had not disclosed, this was a particularly difficult time because couples were staying together, the man was home instead of being away at work, and women feared taking their medicine because that would reveal their status. Quote, "At first, I was affected by those measures, meaning lockdown, because my husband was not working, but later he went back to work. I was not free at home because my husband was always around. I used to take it, meaning the medications, from my friend's place." Another woman said, "Let me tell you the truth. To go for medication, I just escape from home because I don't want to tear my family to pieces," meaning disclosure of HIV status would cause partnership dissolution. People who use drugs are a population that we work with. Quote, "Since we are in COVID, there is a certain time when we are not expected to be out working," meaning sex work, "because of curfew. And that is the time I'm expected to be working. When we are found outside beyond curfew time, we are beaten. Being beaten is not the only problem here. The main challenge is getting a client who wants to have live, meaning condomless sex with you, and is giving you like 15,000 shillings, equivalent to about $4, which could be little, yet you badly need that money. It is hard sometimes to get heroin, and you could be needing it at that time, yet you cannot find it. You have to look for money, and yet where you're looking for money is also dangerous. In such a situation, when you get a client who's willing to give you that money, you end up accepting the offer at the risk of your life. There are times when you get a client who ends up taking the money from you after you have had sex with him. Some clients strangle us to the point of being admitted in Mulago Hospital. And this quote nicely illustrates the overlapping syndemics of drug use, sex work, and gender-based violence. This woman is experiencing violence from law enforcement and also from her clients, and ends up actually losing money and getting physically assaulted. And as you know, in these parts, an admission means out-of-pocket healthcare expenditure. So multiple layers of problems and vulnerabilities for people who use drugs. This work is going to be presented by our colleague Brenda in poster 263. Transgender men are a hidden population that we have recently started working with. Quote, "It was during the first lockdown that I lost my job. I went to the shelter because I did not have money to pay rent since I had lost my job due to COVID and did not have anywhere to go. With the second wave of COVID, I had started my business selling plastics and soft drinks. I got COVID and the business I had started collapsed. I was sick, not working, locked up in the room. I lost my brother who was taking care of my parents, and we did not have money to support my parents since he was the one taking care of my parents. Before burying my brother, I lost a sister to COVID, and we buried both of them at once. I could not bury my brother and sister since I was also sick. I sold some of my things like a fridge to my landlord, got money, and sent my parents money to help with the burial arrangements. So COVID resulted in loss of formal employment as well as loss of self-employment, and also resulted in the death of siblings, and she had to liquidate assets in order to meet funeral expenses. So multiple challenges. When I got COVID, I had no option but go to hospital for treatment. When I mentioned my name, so many questions were asked, and I told them that that is my name, and I asked them to treat me the way I am. So many tests were done, and I was given drugs, although I had to buy some drugs. We trans men fear to go to some hospitals because of how we look like. There are forms we have to fill, and you can write a man's name, and yet when they look at you, they see a woman. We face challenges of being asked so many questions like, are you a man? Such questions prevent us from going to hospitals. I fear so much to go to hospital. Each time I am told that I'm going to hospital, I only think about the many questions I'm going to be asked, and that really scares me. So stigma, healthcare stigma as a barrier to healthcare during COVID. Transgender women are very high risk, about 34 times greater risk of HIV infection than the general population. I was working, but COVID came in, so I lost a job. I would do my job as well as sex work. Now I remain with only one job, so loss of income and somebody having to depend on sex work. However, COVID also created changes in sex work. COVID affected all of us, and by the time it became so rampant, I just bought my smartphone. So I transferred all my business online. And here we see sex work moving off the street and going virtual. So it was not just us doing virtual consultations, other people also doing virtual business. Now I'd like to briefly talk about delivery models as we innovated to take care to clients who could not come to clinics through community pharmacies, peer delivery services, telehealth, and community delivery. We partnered with private pharmacies and drug shops, and you can see in the top picture where a client would come in, you can see the drug register on the counter. And during the lockdown quote, the ART in charge could go and take drugs to them, meaning clients. We go for outreaches and take for them drugs in the community. As you can see in the bottom picture, a healthcare worker out in the community delivering care to a client. However, as we have discussed previously, taking drugs alone is not enough, as we see in this quote. Some ended up missing drugs in that period, meaning the lockdown, though IDI as an organization tried their level best to reach clients and have drugs delivered to their doors. However, with all these other constraints, people were no longer working. People did not have food. You could give drugs to the person, but they tell you, health worker, I do not have what to eat. I have been living on an empty stomach for 2 days. How can I take these drugs? And that's a picture of a border. They're all over Kampala that we used to deliver drugs to clients in their homes. We switched to multi-month dispensing. This is data from TASO in northern Uganda, showing an increase in multi-month dispensing for 3 or more months. The upper plot shows clients older than 15, and the bottom plot shows clients younger than 15, both showing about a 30% increase in multi-month dispensing over the end of the lockdown period in October 2020 to the 12 months to September 2021. We also used peer services to deliver HIV care to participants. This is a quote. During his, meaning the peer, first time to come to my home, I was staying alone. I did not have any problem bringing him to my home because I was renting my own house. So when the COVID pandemic came, I had to relocate my parents' home. So sometimes I face a hard time when he comes home with a bag and start getting out the sample collection kits. So as parents of people who are concerned, they're supposed to ask, who is that person? What had he come to do? Yet there are sensitive issues to explain to someone. You cannot start saying he wanted a urine sample from me. So you have to hide him or tell him to pass behind the house. That is what I face as a person. So even peer services have challenges when stigma is an issue. I think you're all familiar with how we use telehealth using phones, SMS, WhatsApp, and Skype. The benefits are that we're able to continue giving services, and particularly as we're discussing with Dr. Dung over lunch, connecting with loved ones on quarantine and doing public health messaging. I think the role of telehealth in providing mental health could really be expanded, as well as doing pharmacovigilance. I would like to end by saying that our qualitative work found that we faced multiple challenges during restricted conditions of the lockdowns, but the initial bump in service delivery rebounded. Although the impact on vulnerable populations, especially adolescent girls and stigmatized populations, is going to be significant and is probably not fully understood. Healthcare systems adopted a variety of models to ensure continuity of care, and we found that our clients were able to persist in adherence in spite of the difficulties they faced. I would like to thank the following people for their contributions to this work, and I end with a tribute to our young girls who are doing remote learning on the radio, and we wish them a successful career ahead. Thank you for your time.